Anil Guri. I'm a consultant in reproductive medicine and assisted conception and fertility plus and fertility courses. So today I'm going to do an old talk, which some of you all have asked me to present again because it has again taken some importance. And this is this very simple question: is does progesterone lower the risk of recurrent miscarriage, and does progesterone also prevent miscarriage when a patient is bleeding? Now, routinely, a lot of us give progesterone. There's no doubt about it. We give progesterone for recurrent miscarriage. We give progesterone when a pregnant woman comes in bleeding in early pregnancy. And there were two trials in 2020 which basically started answering this question, two very large trials. And let's see what they have to say. Now, if you have a look at this, and this was published in the American Journal of Obstetrics and Gynecology, of using micronized vaginal progesterone to prevent miscarriage, a critical evaluation of randomized controlled trial. So now let's look at progesterone. It is necessary for maintenance of pregnancy. Withdrawal of progesterone with anti-progesterone drugs causes miscarriage. And the ACOG concluded that for threatened early pregnancy loss, the use of progesterogens is controversial and conclusive evidence was lacking. So two major trials came up to create a robust evidence so that we'll be able to answer this question. One was called the Promise trial, and that's progesterone in recurrent miscarriage, and the other was the Prism trial, which was progesterone in a spontaneous miscarriage. So if you have a look at the Promise trial, and it was a well-powered randomized controlled trial, and there were women with unexplained recurrent miscarriages of more than 400 milligram of macronized progesterone was taken regularly, no later than 6 weeks until 12 weeks of gestation, and that was compared to a placebo. The live birth rate was beyond 24 weeks, and 836 patients were seen. And the live birth rate in the progesterone group was 66%, and the live birth rate in the placebo group was 63%. And that was not statistically different. So on the surface, you'd say, well, progesterone is not very helpful. So when you looked at the subgroup analysis, they looked at 3 miscarriages and 4 or more than 4 miscarriages to be able to see whether that would make a difference. Now, when we started looking at, if you look at the overall picture, there doesn't seem to be any difference if you give progesterone. But if you look at those women with 4 or more miscarriages, adding progesterone seemed to make a significant difference. Now, the Prism trial was also a well-powered randomized controlled trial. It was double-blinded, and the progesterone group, the live birth rate was 75%, the placebo group was 72%. And again, what we're looking at is 400 milligram of macronized progesterone twice daily until 6 weeks of pregnancy if you came with vaginal bleeding at 12 weeks. So two different trials. One is for recurrent miscarriage, and the other trial is looking at a threatened, or what we used to call in earlier times, a threatened miscarriage when somebody came in with bleeding. So, and that's what they said. And when I looked at the Prism trial, if a woman came in with 1 or 2 miscarriages, the evidence, statistically, was not very significant. But if you came out with 3 to 4 miscarriages, clearly progesterone seemed to make some benefit in treatment. Again, when you looked at ongoing pregnancies at 12 weeks, at 3 or more miscarriages, there seemed to be a significant difference in ongoing pregnancy rates if you added progesterone. Again, miscarriages less than 24 weeks. And again, what is this evidence coming up? So if you have somebody who's been bleeding, but if you had previous miscarriages, there seems to be a benefit of adding progesterone. Now, what we do know is that 50% of all miscarriages are due to numerical chromosomal abnormalities. And so numerical means numbers, and it's, to a certain extent, genetic screening of embryos looks at numbers, and that is aneuploidy. And trisomy is the commonest. polyploidy or monosomy. And then euploid embryos are more frequent as with increasing risk of miscarriage. So if you have a look at miscarriage risks by number of previous miscarriages, as more and more miscarriages start occurring, it is likely that a large number of those later miscarriages may be euploid embryos, maybe fetuses which are euploid. Now, often what is blamed is a luteal phase defect is blamed, and it's a progesterone-related problem which is given the name of luteal phase defect. So what is a luteal phase? It is a second phase. And what is luteal phase dependent on? And luteal phase to a certain extent dependent on the LH-like activity of which is imposed on the corpus luteum. So get that clear. And so, if there's a good LH-like activity which allows for the corpus luteal function to occur, and that may help in maintaining the luteal phase. And one of the commonest reasons why euploid embryos may miscarry may be because there may be a luteal phase defect. And so this was a trial where 116 women were evaluated in a mid-luteal phase, and the endometrial biopsy was taken to check for the progesterone element. And the luteal phase started microprogesterone 100 milligram every 12 hours, elevated nuclear cycling. Now, what did see in this trial is that when you added progesterone and you try and then correct the luteal phase defect, the live birth rate increased significantly to 68% compared to 51%. So if you look at the target population and the women with recurrent miscarriages, women with early pregnancy bleeding, and which is history of miscarriages, risk of future miscarriages, and which tend to increase, and the risk of miscarriages which also happens with sporadic aneuploidies. Now, if you look at the type of progesterone used here, the Prism and the Promise trial use vaginal macronized progesterone, and it's a natural progesterone derived from soya beans and Mexican yam roots, and has identical structure to physiological progesterone synthesized with human beings. The synthetic progesterones are dihydroprogesterone and 70-hydroxyprogesterone, and they have a different molecular structure, and it has not been used in this study. So at the end, a big study, a fantastic study, but what are the clinical implications in your practice? So what do you take home? And what do you take home to say, how do I use this data to help my patients? Both the trials found a small but a positive effect dependent on number of miscarriages. Now, if there were no miscarriages, there was no benefit giving progesterone to early pregnancy bleeding. And it said that progesterone may benefit or be of benefit if early pregnancy bleeding or there's one or two miscarriages. And this should be conveyed to patients for very much a shared decisions. And if you start progesterone 400 milligram twice a day from the start of bleeding and continue it till about 16 weeks. And what this study found out that if you use that for recurrent miscarriages of more than 3, and if you used it for previous miscarriages with women who came in bleeding in early pregnancies, you'd make a significant impact and statistically have a significant number of babies being born. And that is something which is finally important, is that the Promise and the Prism trial did not find any increase in congenital abnormalities or short-term harm. So, it's a relatively old trial, I'll say 2 years old, but phenomenally good, well-conducted trials which have in fact given us some indication. So, going back to this old way which we thought, and we initially believed that, if you gave a progesterone, it was useful, and then came a phase where we said, well, it's not useful. I think now we are slowly coming back to a phase that we are understanding progesterone better, and we understand progesterone better in our fresh IVF cycles. We are understanding progesterone better in our frozen, embryo transfers. But also, I think we are understanding luteal phase defect better. And believe me, luteal phase defect is not as uncommon as we think. And if we go back to taking a decent history, I think you'll be able to spot a certain number of luteal phase defect patients, and I think they are quite easy to treat. With miscarriages, I think we've got a lot of things to learn, and I feel that the progesterone may be a key tool which will help us to save pregnancies which are euploid. Thank you very much, and do like this page and do share it. And as we spread evidence, is much better. Thank you.